be here. So as the physician on our panel, I can say that doctors actually tend to be early adopters of innovation when we believe the value proposition for our patients is there and is clear to us. This is really our history in medicine, right? If you look at the last century of diagnostic tools and drugs and devices, and we like to think we were motivated by offering the best patient care. Today, we're not only witnessing really stunning progress in immunology and genetics, but we're on the cusp of a similarly, I think, very disruptive innovation in healthcare and care delivery, whether it's using artificial intelligence as decision support or digital medicine to improve access, quality, and value. So today we're really focusing in this session on telehealth and telemedicine. I mentioned I'm a dermatologist, so as a dermatologist, my specialty has sort of been an early joiner in the telehealth world, and we've sort of seen the best of what it can offer and some amazing improvements in access for a lot of our patients, and we've also seen some of the worst in terms of more disconnected health. We've assembled a really fantastic panel this morning to discuss what's ahead in telemedicine. Before I introduce them, I just want to get a sense of the audience. So how many folks in here are from the tech sphere, entrepreneurial sphere? Raise your hand. Okay, how about the provider community, hospital community, and then patients? It's kind of all of us at one time or another, right? All right, so joining us today, we have Todd Johnson, who's the CEO of HealthLoop Incorporated. It's a cloud-based platform that connects doctors, patients, and caregivers between clinical visits, automating patient engagement, and helping clinicians and hospitals monitor at-risk populations. Mr. Johnson's a pioneer in digital innovation in medicine and has helped accelerate the growth of HealthLoop since joining as CEO in 2012. HealthLoop has now been implemented, I understand, in over 40 large healthcare systems. I'm going to go ahead and introduce all three of our panelists before we get started. So also joining us is Clinton Phillips. Clint's the founder and CEO of 2nd.MD and most recently of Medici, an app launched initially last fall and more broadly, I think, this week that allows patients to securely text their doctor or their veterinarian, I think, or their therapist or pretty much anybody else and open new lines of connectivity. His work at Medici builds on his success at 2nd.MD, which provides patients seeking a second opinion with direct access to leading physicians. We also welcome Kim Bond-Evans. Kim's the co-founder and CEO of Seremedi, Inc., the digital health company behind CareScriptions, a mobile care management tool that enables care teams to remotely connect with patients during critical points of care, including pre-procedure planning, which we were talking a little bit about last night. Like all of our panelists, Ms. Evans has an impressive background in digital health and emerging technologies. She was previously president of Blue Lance and CEO of Secure Vantage Technology and had earlier been an entrepreneur in residence for the Houston Technology Center. So please join me in welcoming all of our panelists. So in order to get things started, I'm going to ask each of our panelists to tell us a little bit about your role in these emerging technologies and how you believe they're going to help patient lives and outcomes. Todd, why don't we kick things off with you?
Sure, and good morning, everybody. Thank you. I'm not going to give a HealthLoop commercial, so if you want that, you can find me later. What I will do is tell you sort of a story about how I view the industry and why I think we all know we're living through this inflection point and have a necessity for applying technology to solving some of the real problems that our healthcare delivery system faces. When I look at our industry, I sort of think of it as an animal that has learned to sell tests, visits, procedures, hospital stays, has learned to sell them with incredible efficiency, right? And we've seen this rapid growth of stuff that's getting done, and the result for patients is you get less and less time with your doctor. You're getting discharged quicker. And just the experience of being a patient kind of sucks, right? Like getting in to see your doctor is hard. You're typically waiting longer than you thought you should, and then it's very brief. And patients are discharged and they've got a lot of questions. And I think we rely on hope as a strategy in medicine, right? We meet with patients, we diagnose those patients, we do what we can to synthesize the information and prescribe a treatment, and then we do what we can to educate our patients about what to do. Then we hope. We hope that they respond well to the interventions. We hope that they work. We hope that the patients know what to do. We hope that they do them. And we hope that if something goes wrong, that the patient raises their hand and gets back into the delivery system to get it addressed. And hope is not a strategy. going forward. We're also living sort of this moment in time where physicians are more fatigued now than ever. I think it's one of the job areas where you've got an incredible dissatisfaction, and I think one of the core reasons is spending less and less time really partnering with their patients. We have a shortage of physicians, we have a shortage of nurses, and we have more healthcare to deliver. And it's broken, right? And so how can we scale? And I think the very simple way that I think about technology's role in delivering a new healthcare experience for all of us is, we have, 760,000 doctors in America, but we have 340 million patients. And nobody has more vested interests in getting best outcomes as quickly as possible at the lowest cost than our patients. And we have, as a system, failed to leverage our patients in any meaningful way. And it is an unbelievably vast resource that is motivated, that is smart, that wants to help. And so, I view technology as, can we tap into this, amazing leverage and provide relief for providers and ultimately get better faster. So I'm going to give now the 30 seconds on how we do that, and then I'll pass it on to Clint. So how we do that is using automation to reach out to patients every day and remind them of what to know, do, and expect, calm anxiety, assess their current status. And if the technology detects that something's wrong with this patient, we can notify the clinician's team to follow up so that the patient gets the right information at the right time, it's actionable, it's guiding them, it's participatory, but then the providers get the right information at the right time so that they can focus on the patients that truly need their help, right? And together we sort of partner to get better outcomes, and we measure those outcomes. So that's a little bit about how I see the world.
Great. Thanks, Todd. Clint.
Thank you, Doc. I am the angriest healthcare consumer and the most disgruntled healthcare provider imaginable. I grew up in South Africa, moved to the US. Things work so much better in the US, except for one thing, and that's healthcare. I know you're thinking politics, but I'm not going. We are, 7 years ago, I had a clinic in Aspen, Colorado, beautiful place, helped people avoid back surgery, but when my own daughter suffered a stroke, we realized how impossible it was to speak to a specialist. We needed a pediatric neurologist. We had to travel the country, fly, go through all these issues just to have a conversation with somebody. We started a company that would allow people to have second opinions with top doctors, and it was all virtual. And we realized what was really missing out of healthcare was not technology, it was technology that consumers and doctors could actually equally enjoy, and having a good appreciation for some of the barriers that patients and providers both struggle through. More recently, we realized there was an even larger issue across the world, really, and that was the ability of communication. Healthcare had so invested, you heard what Todd said, I look at it as reimbursement. Healthcare in the US is so focused on reimbursement that they forgot how to communicate, they forgot how to get engagement. And so we launched a service really yesterday nationally called Medici. Some of you are wearing it around your necks. And it's the ability for you to communicate no matter where you are with your providers. And that's more than just your doctor, that's your specialist, that's your veterinarian, your psychologist, etc. And very honored to be here on this panel with some very smart people.
In 2012, I got a call that nobody wants to get. I got a call from a relative saying your mother has been admitted to ICU. She was traveling, visiting her sisters, and so I got on a plane, and in the surgery, she went into ICU as a result of multiple surgeries. She was a very active. She did ballroom dancing as a hobby. So very active, vital, and was convinced to have spine surgery to relieve her some back pain. One surgery turned into multiple surgeries. And in 6 months, she went from being very active and vital to being a quadriplegic and then passing away. So unlike Jack, I didn't choose medicine. I actually was ejected from a plane into enemy lines and had to quickly figure out how to navigate that situation, being my mother's healthcare proxy. Her condition was really a result of miscommunication, missteps. And I just thought, you know, there's just a different way to do this. So I started a company to fix it. And we are totally focused, laser focused on making sure that patients who have surgery and should survive, do survive. And we provide that mechanism to do that. So I'm totally in line with what Todd said. Patients really have to be involved in the process. And I think that the good news is that there's technologies, whatever your choice of that technology is, to really move the patient from a passive participant who's waiting for a cure to being part of the cure. And we're in really that stage where that's possible. So I think over the course of this panel, we'll hear more about how patients and care teams are working as a team to create better outcomes. My company is certainly facilitating that.
Great, thanks everybody. So the first topic I want to talk about a little bit is this issue of fragmentation versus interconnectedness in healthcare. I think, you know, from the physician community, we've spent a lot of effort in the last decade trying to deal with silos in healthcare and break them down. So the traditional in-person healthcare system where you have literally paper charts sitting in somebody's office and you go see another physician or show up at a hospital or emergency department and nobody knows anything about your history. But I want to make sure that we avoid building a whole new modern digital health world that just repeats those same mistakes. In my own specialty in dermatology, we've seen a lot of direct-to-consumer online providers that essentially are functioning like prescription mills. I had a patient show up in my emergency department in my hospital last year who essentially used one of these services for their acne, fairly simple condition in their case. Were prescribed a bunch of antibiotics, had a medication side effect, reached back out to their digital health company. The person basically said, well, we don't have anybody to go see in person in your area about your side effect, just go to your local emergency department, which is sort of not an efficient use of resources in healthcare. So, you know, and then we moved on to electronic health records where we've now depended on a lot of help recently from Andy Slavitt, who was just head of Medicare for the last couple of years to try and break down data blocking. What are we going to do? How do we steer things in the digital health sphere to break down some of those barriers and make sure we don't create new silos? Any of you in particular want to take a stab at that?
I'll take the first stab. You know, I've been in health IT for 20 years, and it's a sorry state of freako system. Those providers in the room kind of understand the brain damage of moving information around, and I think that the healthcare community has been really underserved by technology, candidly. And so it leaves us in this kind of in-between state, right, where we have this easy, consumer, delightful technology that could acquire health information and make it available. And yet you've got providers that are sort of stuck, or, you know, and necessarily, I don't like to bash EMRs. I think it's hard work to do what those companies have done. But I think necessarily healthcare providers need to have all the information in front of them when they're making medical decisions about a patient. I do think the work that Andy Slavitt did at CMS around interop is a good start. I think we have a long way to go. I think it will be years before we have truly sort of API fluid access to information flowing through the healthcare delivery system. So my perspective, like it or leave it, today is, actually one more piece before I kind of add my perspective is, and we've had a consistent failure to develop a personal health record. So sort of a very obvious, simple, and natural solution here is we all have an electronic personal health record, and you can go to the doctor and you plug it in, right? And they can read it, they can write to it. Seems really simple, and we have failed and failed and failed and thrown hundreds of millions of dollars at this, and we can't get things to stick. So my unfortunate resignation around where we are right now, while I'm hopeful that we'll have a landscape that is really dynamic and interactive and leverages all the obvious things that Silicon Valley does today around APIs, is you got to work within these EMRs. You got to make sure that data does move as best you possibly can, because providers need to make medical decisions based on accurate, timely, relevant information that's together. I don't know if you guys have.
Anybody else want to tackle interoperability as well?
Well, as my mother always says, follow the money. And we expect that healthcare should have different principles around how it's set up. But when we look at the incentives for a EMR to be interoperable. Even if they wanted to, the health systems are going to say, why would we want to share that information? There's no incentive for them to be able to share it just because it makes your life easier and plugs into those pieces. So it's been very disappointing to see that the protection of revenues has often preceded the idea of let's make this incredible for our patients, our doctors. Executives are being judged on revenue, not on metrics of is this making life better, is this moving healthcare forward? And that's where I would love to see executives celebrated on. We trimmed revenues, we trimmed, we lost revenue that we had got last year, but look what we've done for our community, look what we've done for patients, look what we've done for the healthcare landscape. I think that's what's really needed to celebrate, because this idea of fragmenting, my daughter's medical records are spread across urgent care, some televisit, the hospital, the doctor. She's 7 years old and she's got records in 15 places. It's ridiculous. And we have to go through the effort every time to be able to work to get those together. We're glad to try and solve it.
Yeah, we've had this plethora of data. It's not a shortage of data in digital. To me, the gift of digital is really being effective translators of that information, make it meaningful. Never will forget, I'm sitting in a room one day and I'm trying to understand what was going on, what was the state of my mom. And the doctor says, it's all right there on the monitor. I'm like, that might as well be in German. I have no idea what that means. What I want to know is really, when you think about it, there's only 3 states a body can be in. A system, whether it's a human system, it's either stable, it's getting worse, or getting better. I want to know the metrics that tell me that. And I think that's really, we have to kind of distill information down and translate it to where it's actionable and meaningful, not more, but less. And I do think that is the gift that digital can provide to not just clinicians, but families who are going through these crises.
Good point. I'm going to come back to that one in a minute, the distilling down piece. I want to talk for a minute about coverage and payment, which came up a little bit in some of your opening remarks. So Clint, Medici's really set up for self-pay, and clearly there are a lot of patients out there who are willing for convenience or to be able to continue to communicate with their physician to put a credit card in or pay for it. But very few insurers are actually covering follow-up care with existing healthcare teams. We are seeing a lot of health plans sending postcards to people saying, we'll waive your copay if you use Teladoc or Amwell or one of these companies that'll hook you up with a care provider that's not part of your existing healthcare team. But very few of us are able to get compensated for actually doing follow-up with patients who know us. Do you have any thoughts on how we can advance coverage and payment? Because not everybody out there is going to be able to afford to pay for this on top of their healthcare premiums and copays.
Great question. What's very interesting is that people are, when we do care efficiently, we've got doctors that are treating people for the price of a copay. So you can either go to the doctor, pay your copay, and then be billed a whole lot more, or you can actually use Medici, pay your copay or the equivalent, and not have those additional costs. So we found that doctors are willing to work for 50% less of what an office visit would be if you can make it easy for them, if you can make it efficient for them. The move of people towards high deductible health plans, people are coming out of pocket anyway. So let's give them a vehicle where if they come out of pocket and spend $25, $50, $100, let's make that money go as far as possible so that by the time if they have to reach their deductible, they've had incredible care. And we've seen people have 20 visits with a healthcare provider for $500. That can be eaten up in 2 visits. So the idea around using high deductible plans and some of the things that are already in place, health savings accounts, cash being one part of that, but I think if you were isolated completely to cash, you're going to have limitations, but we are slowly seeing how far we have to be able to work with carriers without abiding to every one of the difficult restrictions that they make. But we always look through the eyes of the provider does this make sense for the provider? A $25 visit may make sense for a consumer, but if it doesn't allow the provider to do their work adequately, properly, allow them to cover their costs, we have failed to make that interesting for the provider.
Kim, some of your work is with hospitals, and they're already potentially getting, in many cases, diagnosis-related payments, or are already incentivized heavily to avoid readmissions and things. Is this an issue for you, or?
Yeah, I mean, we were at a hospital the other day, the bundle payments. Many of them are embracing the new alternative payments, and they were explaining to us that although they're doing more work and the cost is the same, the reimbursements are different. They're making less money. So we were working together to see how we can make the process more efficient. How do we make sure that we eliminate procedures that are just simply not necessary? One of the ways that our customers are doing is really looking at, the good news is they're looking at the whole care process, the whole continuum, and saying, what can we eliminate? What do we need more of? What do we need less of? And really re-engineering that whole process to drive the cost out and really increase and put efficiency back in the process. So the curve of revenue is not going down, although the work effort and cost is going up.
Yeah, I think I might have a slightly different opinion on this, and I hope I'm not too forward-thinking in terms of how quickly the industry is going to move. I think that like these transactional reimbursement models just need to go, and when you focus on quality, there's unbelievable profit to be made when you cut out stuff that isn't useful. And I am a huge believer that physicians are in the best position to make decisions around cost-effective, high-quality care if they have the right information and the right tools. And a simple example of this is bundled payments. If you look at the total joint care program, the national average for discharging patients to home as opposed to a skilled nursing center or long-term care is something like 60% of patients-ish are discharged at home. When you've got digital tools to support patients and monitor their progress at home, that gets up to 92% of patients. And so the net difference between 60% of patients and 92% of patients discharged at home, every time you avoid sending them to that skilled nursing facility, that's 10 grand, right? 10 grand that the doctor or the hospital in a gain-sharing agreement get to pull back into their pockets. And if you just think about the economics there of a doctor who traditionally made $2,000 for that procedure, and now that they can split 10 grand with the hospital for that same case, the economics start to stack up wildly interesting. And why? It's because we can find more efficient, cost-effective, higher quality ways to deliver healthcare by leveraging digital assets. And so my hope and aspiration is that we continue to really press on moving the incentives around so that physicians can make those smart decisions.
I want to second that from the medical community side, because I think there's I think physicians want to have a lot of choices about models, and I think in different specialties and geographic locations, there are going to be different things that make sense for different populations. We're working very hard towards physician-led alternative payment models. We are struggling a little bit with some of the current rules around, particularly in the Medicare system, where the way advanced alternative payment models are being set up, the risk is much higher than the potential reward, the amount of risk that people are being expected to take. But I think this is clearly going to be our future. Ken, you look like you had a...
Yeah, I just wanted to say so we work with teams, with clinical care teams, and they're really looking at the entire scenario from the time the patient's scheduled for surgery until the time that they get the clean bill of health. And we're actually plugging into logistical systems, supply systems, because that also is going to be part of how this drives out. So it's patient care, it's supply utilization, availability, making sure that when the patient goes home, if they are going to be mobile, that they have the equipment that they need to make sure they don't have a fall, which could cause a complication. So I think it's really looking at this whole continuum in a broader way to make sure that the supplies and the everything is in place to reduce the cost.
Todd, quick comment?
Yeah, just like this is a great little story. At Johns Hopkins, one of the hospitals there, a guy named Dan Brotman did a study like 2 years ago that he published, just by when he was ordering a lab test, this is inpatient, so ordering a blood panel or something, just by putting the price next to the order, all of a sudden doctors started to say, well, do I need the full panel or can I get the subset? They saw a 17% decline in the price of order.
No, I think we would love at the point of care to
Simple,
know
right?
cost.
So
The problem is it's getting harder and harder to do that. I've been arguing a lot lately around the drug pricing and having transparency at the point of care. And many of you who've been patients lately may show up at the pharmacy and get a very a surprising bill, and we'd actually love to know what drugs are costing insurers, what the kickbacks are from pharmacy benefit managers back to manufacturers. So I think around multiple areas of healthcare, we want to work with you on that. We are going to open this up to audience questions in a few minutes, so start thinking about things you want to ask, and we'll transition to that soon. I want to bring up a somewhat controversial area, maybe for a meeting like this, which is the potential downside of convenience. Sounds weird for a physician to say that, but so we clearly have many patient groups who suffer as a result of lack of access, and in particular areas especially, right? So you think about mental health and access to psychiatrists and others. You think about substance use disorders. There are areas, Clint mentioned an experience around the pediatric subspecialty where it was hard to get access to care. I mentioned earlier sort of what we're seeing, though, in the most rapidly expanding areas of telemedicine is often sort of the low-hanging fruit for acute care. There was a study, I don't know how many of you saw it, that was published in Health Affairs just this week where they looked at a contract between the California retirement system and a large direct-to-consumer provider of telehealth, and they were looking at several 100,000 patients who were in this program. And they looked at respiratory infections, largely common colds, and found that actually costs went up and not down because while the cost of an individual visit went down, patients were using this service essentially to reach out when they had common colds. And it brought up all kinds of problems. A lot of times in these cases, we're seeing really bad antibiotic stewardship where these services are giving people antibiotics for viral respiratory infections that don't need them. So how do we expand access for telehealth in the areas where it's actually going to make a difference on value-based care? It's going to make a difference on quality of care and not just be a convenience play for some of these companies to make a buck off of people's urinary infections or respiratory infections or poison oak.
I'd love to answer that. In that study, I think there were some errors in the conclusions that were drawn. One of them is that people were not able to get help by using the big telehealth service, so they would still have to go to their doctors when they needed their doctors. So the idea that you could directly access your doctors makes a huge difference, and I think we have to give telemedicine a chance to run and make a few mistakes. The idea that there may be a cost here or a bump there or a wrong medication, when we're talking about just in Texas, there are millions of rural Texans that with no access to care, and everybody's quick to highlight this case didn't work out, yeah, that case didn't work out, but this is adopting and changing very quickly, and we see healthcare trying to augment telemedicine into their practice. We think that's the wrong way around, that we think telemedicine, I hate the word telemedicine because you've seen all those pictures of the stethoscope coming out of the computer. If you've got that on your website, get rid of it. It's awful. Telemedicine, a better word for us is communication. So for us, it's mobile. We are taking mobile and we are allowing healthcare to be built on top of communication versus just saying, well, maybe we can do a few cases a month or a few cases a week. Let's do 80% of our cases with our own providers virtually, and then you get rid of a lot of it, but allowing some of these companies to have got their models, it's proven that didn't work as well, it invites the next model that makes a better one. But to shoot down telemedicine because this company did it the wrong way, I think is
so I'm a fan, so I'm coming at this not with the goal of shooting down telehealth because I actually believe in it, and I think it is a lot of our future in healthcare. And when I shoot down telehealth companies or practices by telehealth companies, it's really around the goal of not wanting bad apples to ruin it for the rest of us, because I think this is a real risk. And there are of course going to be bumps in the road early along the way with any new technology, but we literally have health plans giving millions of people access We have a large insurer in Connecticut that sent all of the beneficiaries, the patients in Connecticut under their plan, a card encouraging people to use one of these services, saying, you don't really want to go to your doctor's germ-infested waiting room. Do you use this? So it's expanding very rapidly. My group did a study where we had medical students actually submitting fake cases, standardized fake cases, to all the dermatology telehealth providers we could find in California. And we used pictures, these weren't pictures of the actual students that we just downloaded from the web for these different cases. Not a single site checked the identity of any patient, so these were all getting prescriptions and nobody did any ID checking. That can be fixed over time, but that's a problem. None of them questioned the authenticity of the photographs. Less than a third gave anybody any choice of what clinician was going to ultimately see their case. So very different than what you're doing with working with practices to connect them to existing patients. Only 26% said anything about the licensure of the clinicians who were getting the cases. Some of them actually sent the cases to international folks who weren't even licensed in the US. And the diagnostic errors were rampant. And we don't, diagnostic errors get made in person, but there was no give and take, which telehealth can do, right? So you can digitally ask patients questions and have a back and forth, but none of these services were doing this. So prescriptions were just written rampantly for everybody, not even consistent with the standard of care if their diagnoses had been correct, which in many cases they weren't. And maybe worse, almost none of, very few of them offered to send records to the existing care team, or when they did say you need to go see somebody in person, suggested anybody or help them get an appointment. So I just think before we unleash this technology, we actually do have to think about quality, and it's important.
Yeah, Clint is right. We're going through a growing phase. This is nascent. We're learning how to really use this technology effectively. But I think the answer in large part is going to be education. We had a situation where our mother, Cynthia, was using our technology with her care team. So she's single mom, 16-year-old son who had a kidney and a lung transplant. So the care team was really careful to educate Cynthia, but she didn't really have a big support system. Here are the symptoms you want to be mindful of. If Tyler has these symptoms, then we need to know about it. These are not so much. He's going to be all right if he experiences these symptoms. So she was educated on really what is alarming and what's not alarming. The vitals, the thresholds, she understood what thresholds were good and what was bad. And she did end up using the platform to call in, because Tyler was having a panic attack, and she just really couldn't calm him down, which was affecting his care. But she knew, she had went through all the whole list. Okay, vitals are good, his symptoms are not alarming, but I'm gonna call my nurse, and she knew who to call. And then the nurse walked him through some breathing exercises and calmed him down. But I would say
that's a great use of
that's
telehealth.
exactly right. Yeah. And so the key to that was education and just this agreement on how this is going to work. This is how we're going to work together. Here's what you do. Here's what I do.
Yeah, sounds great. I have a
one little thing. So a friend of mine is a physician who started a telemedicine company, virtual visits, video visits. He couldn't get it to work because there were other bigger companies that were more funded, had better management teams, so they pivoted. And he turned his into a medical marijuana prescription business. Hey, call, get an appointment with the doctor. He'll see you now. And I'm guessing 99.9% of those consults end up in a prescription for medical marijuana, because that's what the exchange of value is all about. I think that telemedicine, and that's like the URI case, it's like there's this expectation that you're buying this service. And to me, I think there's a resolution here. And computers can help do assessments and make recommendations on treatment options, and maybe the computer is the one that can say, no, this isn't appropriate for you to get an antibiotic or something. And then the doctor can be a consultant to help evaluate the treatment options and make a decision.
So I want to get our audience involved. So are there anybody who has questions? If so, would you mind popping up and just coming to the microphone and tell us who you are and in one sentence what you do, and then we'll take a question.
Good morning. This is really great. You guys are great. My name is Michelle Werner. I work for Providence Health and Services, and I am the Senior Product Manager for our virtual program. So really interesting conversation you guys are having. One of the challenges that we have, we are providing common case virtual visits for like $39. And we are seeing adoption, but the ramp is slow. But one of the things that we're really particular about, all the stuff that you said in the secret shop that you did, we provide, we make sure to check IDs. We're very strict about stuff like that. One of our challenges though, and I think you find this in a lot of the things that we're trying to do from a digital perspective, is we tried to do some pilots where we actually did telehealth within a primary care setting, and we couldn't get the providers to adopt it. And part of the challenge was they're so busy with their current workflows that they just would forget.
Yeah, I mean, it's pretty clear that you have to carve out, healthcare systems have to carve out time for people to do this work, because right now, those of us who are engaged in it are doing it after we put our kids to bed at night, right? So it's an important thing. Has the health system had any success in trying to create
I've got a simple solution for you. It's called pay them. Pay them extra. Every facility that wants to put a program in place doesn't want to pay the physician anything extra to do it, and it fails. We go in and we say, are you willing to pay the physician? Here's how you get paid. And all of a sudden, it's amazing. The physician says, okay, I'll do this.
We did pay them. We paid them the same rate as if it was an in-person visit.
Yeah.
It really was more about, it was such a heavy lift to get the front desk people and everybody, they were afraid to use it, afraid to offer it. And we spent a year on it, and we never really got the volumes there.
Did you put it on their phone? Did you make it easy for the physician to be able to?
I think that's a place of improvement that we could have done, for sure. It wasn't a phone-based thing. They had to be at a desktop.
I think this illustrates there is clearly, we heard follow the money earlier, but that's not the whole story, because I do think physicians are overwhelmed with their sickest patients and just the work of taking care of what's coming at us all the time, and figuring out how to organize the information so it's efficient. And I think some of people's early experiences, that's not what they found, so now you have to kind of win them back over. But yeah, thanks for bringing those points up.
Thank you.
Good morning.
Hi.
Hi. My name is Gustavo. I'm from Brazil.
Welcome.
Thank you. And I'm CEO and founder of a startup called Dr. Já, which means Doctor Now. We do low-cost appointments for the people who are uncovered by the healthcare insurance. In Brazil, there are 152 million without healthcare insurance. We came from a country with a public health system, but it's broken. So it's similar to Canada or to England. So basically, my question is, and I'm not a specialist in the health in the US, but I read that there are more than 48 million people, I think, uncovered by the healthcare insurance. I can be wrong, I'm not sure. But how we can have access for health for these people? I think Phillips talked about millions of Texans that they don't have primary care access here. So how do you think that we can help these people have access for primary care?
Universal health.
Yeah.
Medici. It's what we're trying to solve. So I don't think there's it takes engaging physicians, making it easy for physicians to want to be involved in a model that allows them. You have to consider the laws. Are they allowed to practice in that capacity in that state? How do you make it safe for the physicians? How do you keep the quality at the point Dr. Resneck was making? So technology has to be at the center, because if people are uninsured, it means they're uninsured because there's a cost problem. There's some affordability issue at the end of the day. And there's no easier way than to lower cost than use some type of technology platform. And people in Brazil have mobile phones. So it has to, a doctor, a payment mechanism, a mobile phone, and most of the way there.
Todd brought up earlier, we do have an issue with workforce here though, right? So American Medical Association, we're strong supporters of expanding coverage and insurance, and we supported the ACA. But but you have to have people at the other end of that coverage. And so I think a lot of what we're hoping for in digital health is improved efficiency, because you mentioned primary care. We don't have a lot of primary care physicians twiddling their thumbs in the country with just uninsured patients who can't go see them because of coverage. We absolutely have patients with huge coverage issues and cost issues that limits their access to care. It's a real and enormous problem. But we also have a problem even among the insured getting access to both primary care physicians and specialists. So hopefully technology can help us with that, and keep an eye on what we do over the next few years. Hopefully we'll continue to improve that.
Thank you.
Next up.
Hey, Sean Tassone. I'm actually an OBGYN here in Austin, and I think Clint would call me an early adopter of Medici, aka beta tester. My wife and I practice together. She's also an OBGYN, so our kids basically grew up thinking you're always on call. But my point, I think, that I would like to bring up is, for the two of us to run our brick and mortar office a month costs, before we pay ourselves, costs $80,000 a month. So we have to keep that machine going.
Does that include reliability premiums?
Everything.
Yeah,
That's
okay.
basically per month before we pay ourselves. So you have to see patients, or you go out of business. And there isn't a lack of patients, but I guess I'm not old enough to be completely cynical, but I'm not young enough to be completely idealistic. I guess I'm pragmatic. So not just the workflow issue that was brought up earlier, because we are busy. I have found a way to use Medici and use it well for post-op patients that can't come 5 hours to see me, which is wonderful. And I'm really behind this movement. But I think there's a fear amongst doctors. One is that if I can't generate the 80 grand, how do I transition out of my brick and mortar? And, you got to make it work. But fear of litigation is a big thing that I don't think we look at. And fear from my medical board that they're not adopting telemedicine yet. That if I treat somebody for a UTI and they get pyelonephritis, that they're going to come back and come after me as the provider for not seeing that patient, even though all I'm going to do is say, oh yeah, you got a UTI.
Yeah.
But you know what I'm saying? I think there's a fear there. So one is the money. How do we monetize it to work? As horrible as monetization is, and single payer would be great, but how do we get over the fear?
We've worked a lot with the Federation of State Medical Boards, and I think over the last couple of years on this issue of telehealth and licensure and the standards people are going to be held to. And there are two sides to this, right? One of which is we don't want people held to unrealistic standards by telehealth. We don't want the standards to be higher than they are for in-person care, but they should be the same. And if you're seeing somebody for a condition that would require looking in their throat or looking in their ear or doing a pelvic or something else in person, and you can't do that via telehealth. Now, there are technologies for looking in somebody's ear via telehealth that are emerging. Then you probably need to see that person in person, and we would expect a state medical board to hold people to that standard. And there are problems with people just writing the prescription and not doing that. On the other hand, if you're offering the standard of care to a patient that you would have offered in person via telehealth, most of the state medical boards around the country have come to recognizing that as basically evaluating it in the same way. But it's a good point. I think we need way more communication to physicians around the liability issues.
Yeah,
Anybody else want to take that?
We've worked with hospitals to really kind of look at the legal aspects of it. So a lot of the contracts where we work, the contracts have been updated, where patients understand, we're now, half of your visits will now be virtual. Or do you accept that? And so there's just, again, some level setting on the new way of doing things. Everybody understands there's new tools and new rules that are associated with that. So we've updated some of the legal aspects of those agreements. Patients have to sign off on that. We're not customer facing. I am involved with the clinical teams, but the hospitals actually provide these agreements for the patients to sign. But, clearly where we are right now, I think, at least maybe I'm saying in my bubble, the realization that we are at this kind of place where hospital or healthcare organizations understand they're either going to be a beneficiary or a casualty of this transformation. They have to do things different. And what has been going on is not going to get them there. So there's really more of a acceptance and openness to changing things across the board to make that happen.
Yeah, we've even seen some telehealth providers who are claiming this is not a physician-patient relationship. This is essentially, quote unquote, for entertainment purposes in the small print, but that people are using it for healthcare. So I mean, I think what you're doing with your patients on Medici sounds very different than some of the other things, but we do need adjudicators out there.
We're actually working with a medical malpractice carrier. When you look at claims, 90% of malpractice claims are communication issues. Like 9 out of 10 patients say they never would have sued their doctor if they'd simply felt that they had been heard. So I think this is a tough issue. I don't know if you've ever been sued, but it sucks, right?
I can't imagine.
Yeah. You know, a doctor that's out there trying to do the best for their patients and all of a sudden gets a lawsuit, it rips them apart. You know, and it's stressful and it's anxiety ridden. And so I think that there will be a body of evidence that proves, guess what, when we over communicate with our patients and do more, it reduces our liability and it will become generally accepted. I think the only silver lining I saw in the American Health Care Act this week was the Trump administration proposing putting on limits of liability around medical malpractice. So that might be good. I don't know.
I just want to say one last thing. Last night as I was watching the University of Arizona kill UCLA in basketball, in my bed, I got a text from my patient on Medici. Her hormones weren't working right, and she was having all these headaches and everything. Well, through the app, I found out she was taking the patch. She was changing it twice a week instead of once a week. And so I was able to fix that just over the phone, which if she would have been able to contact me, she would have called one of my partners who wouldn't have known what was going on because they didn't have the EMR. So
Huge benefit to two-way
kudos to all that.
communication when it
Thanks,
works
guys.
well.
Did you pay
Thanks
them
for
to say
sharing
that?
this story. Next up.
I'm Jeff Reno. I am a writer for a company that makes cloud-based devices for healthcare, so I do a lot of research in health and technology. And so I have a ton of questions I'd like to ask, but I'm going to keep it to one. And that's, in the time that I've researched this, I found that a major issue with adoption of technology is that HIPAA laws were written 10 years before smartphones were even invented, right? So how are doctors getting through HIPAA laws? Do we need to be educating patients on data security? Do we need to be educating government on why HIPAA needs to be updated? How are you working around HIPAA laws to keep patient data secure? I guess I'm asking more than one question, I apologize. So how do we keep patient data secure via apps like Medici that are phone and text-based? Like, how are we working with that, and what changes need to be made to really make this a
We'll let you
success?
get away with the multiple questions because at least they were all in one category. So yeah, thank you very much. So security and
Yes.
HIPAA and High-Tech Act.
It's when we brought in somebody from Amazon to keep us safe ahead of our Chief Information Security Officer, we looked, and a lot of these regulations are not that dissimilar to banking. We have to keep people's information private. We have to make sure that they've agreed terms on certain sides, and we have to look at healthcare information. Isn't that different in that it needs to be protected just like other sensitive information? So there's often a very big scare around HIPAA. If you keep information safe, you notify people what you need. We don't see it as the same as a very different beast to other pieces of information. You know that I'm going to protect this information like it's my mother's information. Who has access to it? Creating an audit trail. It's not as, HIPAA often gets blamed, in my opinion, for a lot of scare when it's actually very common sense.
Yes.
This is important information that you need to keep private. So just as you're protecting other apps around financial things, there's a lot of crossover to what medical needs.
Yeah. Before I was, as I started this presentation, I didn't choose medicine. I was ejected from a plane into hostile territory. So before I entered this, I was a cybersecurity forensic specialist. So as Clint said, this is really not that different than precautions you ought to be taking for your banking and just your personal information anyway. There's some variances that we may have, like, for example, one of our customers is a well-known cancer institution. So we do notify patients when certain events are occurring, and we make sure that because this brand is so strong, we don't identify who that is, because in some cases, unfortunately, patients won't even tell spouses that they have cancer. It's just crazy. But it's, there's a lot of people want to protect the kind of treatment that they're getting. So we do have to, it's situational. Certain institutions, we will make sure that that information is, there's some additional protections to protect the patient.
Thank you.
Sure. Go ahead.
My name is Logan Plaster. I'm editor with Telemedicine Magazine. You guys touched on a bit about physician reimbursement with my gentleman, the OB. But Clinton, you said something that interested me, which was that you talked about physicians being willing to receive less if they are getting certain conveniences. And so I was hoping that you three could talk, or four could talk a little bit about overall trends in physician reimbursement as digital health technologies might drive that individual reimbursement down for individual physicians, and we see the incentives shift, and we see just the financial models for practicing physicians change as these technologies are presented to them.
Yeah, I think everybody here could answer that. We look at total cost of care. So SecondMD, our second opinion company, supports many Fortune 50 companies, and they are wrestling with these major costs. And one of the areas we found, if we can help you avoid unnecessary procedures, costs come down. So we can actually afford to pay certain physicians a lot of money to give you a second opinion, because the outcome or the impact of that is significant in overall cost. When you look at everyday pieces, we have to make it, the pressure on physician reimbursement, when you see what they come out of school with, the debt that they're laden with, they have to make an income. When you hear what the Dr. Tasson says around his overall cost to be able to manage a practice, it's significant. Doctors have never been able to earn money outside the office. My accountant, I don't know where they work from, they may be at home. My lawyer, I don't know if she ever goes into the DC office, but doctors, I know exactly where the doctor is. They chained to their desk. So the ability for them to actually be able to earn outside is incremental. Right now they're getting all these portal questions that they don't get reimbursed for. Just adds to their load. So overall, their ability to take care of more patients is decreased because of the management around those pieces. So I think looking at it at macro level, looking at it at micro level, there's a lot of opportunities, but often physicians are just seen as a commodity. All physicians are the same, so just pay them the same, and it drives me crazy that I can go to a doctor down the road as a cardiologist who leaves me waiting for 3 weeks before seeing me, 2 hours in the waiting room, unfriendly staff, gets reimbursed the exact same as the guy across town who gives an incredible experience, the right diagnosis, is spot on with everything, and they get reimbursed the same amount of money. So there are some marketplace things, in my opinion, and it differs to some of the other pieces, that you have to have some market influences here to recognize physicians who are doing fantastic work, who are providing value, who are creating value for the patients, for the employers, for the payers that they serve.
I guess I would just sort of add to the thesis that I stated earlier, that there's a lot of money to be made in higher quality, lower cost care. And when you empower physicians with the tools that they choose to adopt to deliver that higher quality, lower cost care, and then give them the reward of lowering that cost, they're gonna make a lot of money. And there's some extremely obvious things to do with technology that can, we talk about post-op visits. Yeah, you know what? You go into the post-op visit, they look at the thing, they say, yep, you're fine. Well, they can do that looking at your phone, snap on your phone. So there's huge opportunity, and I believe doctors are really smart people, and they will figure out how to make that opportunity into additional income using all these tools, right?
AMA partnered with RAND last year to do a pretty large study. You probably saw it around issues that both satisfy and dissatisfy physicians. And again, it's frustrating to get penalized for giving good care, but at the end of the day, it was quite uplifting to see that a lot of what we saw in the survey was not about money and compensation. It was people derive satisfaction from their work when they're able to deliver high quality care to their patients, and when things don't get in the way of doing that. So the EHRs of the last decade, or the other things that wouldn't surprise you that we hear about from physicians. So I think, yes, we're pushing for alternative payment models that give people more flexibility to use telehealth. We're pushing for Medicare to not essentially be a stick in the mud and block use of telehealth, except for in Alaska and Hawaii. And so yes, we need coverage and payment so to help these things happen, because physicians have to pay the bills at the end of the day, but I don't think those are the primary drivers. Before we run out of time, I wanted to bring up another issue, which I think a lot of our audience is going to be walking around this meeting and seeing very cool things around sensors and new technology and the Internet of Things coming to healthcare. And if you're here, or if you go to the American Telemedicine Association, this is lots of bright, shiny objects out there. And some of them have real potential, I think, to help us take care of our patients. But again, from the user end, at the physician side, I have two big concerns, and I just wanted to get your thoughts about these two things to help people evaluate some of these as they walk around. First is the obvious sort of accuracy and validity, right? So you saw studies recently of blood pressure apps on your iPhone that essentially are random number generators. We've seen some in dermatology that supposedly evaluate your mole that it turns out are totally worthless, which someday we will have better versions of, I'm sure. EKG things that you attach to your iPhone that essentially spit out what a textbook says it should look like instead of what's actually going on. And then in some way, that will all get fixed, I think, but even the more concerning thing is we've got the people coming together to create the technology, and Clint mentioned this earlier, who are not bringing the clinicians in on the ground floor. So, we talked earlier about physicians having time to deliver telehealth and not doing it at night. Well, there's an impression that, sitting in my office, a patient's gonna come in with their 8,000 blood pressure readings from their new and improved Fitbit-like device, and what am I going to do? They're not organized in a way to be helpful. And I think a couple of you have worked pretty intensely on creating information that's actually useful to care teams. Do you want to talk about how that relates to the Internet of Things, or give anybody a primer on what they should look for walking around?
I'm very excited. I try everything first and foremost. So when they started testing your DNA, or there's an app that does your blood pressure, I realized you've got to give some of these things a lot of time and support. One of my comments is, firstly, we haven't brought most of the world onto just basic healthcare. So the idea of going all the way into making virtual reality office visits, we can do that. But in a world where most people still can't just have a conversation with the doctor, it seems a little bit out ahead of where we are. The technology is incredibly exciting when they can get some data behind them and we can actually see what they are. Our commitment in the whole role is to make it easy for physicians to be able to consume this information. When hundreds of lab tests come in, when literally we have collected records for people and there are 100,000 pages. 100,000 pages. What doctor with 2 years is going to be able to even go through that? So they chuck it and they worry, they either don't look at it or they worry about liability. So creating opportunities for this data to be easily consumed is something we're very committed to. Whether it's a score, whether it's just an arrow going up, down, sideways, being able to take that and visualize for the doctor, because otherwise all this information will actually be resisted by the physician because they go, I don't have the time to look through all of that, so why don't you just put that aside and tell me what's wrong with you? And now you've gone through all this data gathering and the doctor doesn't even want to deal with it. So I think the companies that will be successful will have opportunities to make that data easy for a doctor to consume in seconds. Is the only opportunity for that to really work.
Todd, or Kim, any final thoughts about organizing data?
Yeah, I do. I think that these devices are going to land in, there's going to be consumer devices that are for fun and fitness and all that stuff. And I think medical grade personal devices will have tremendous opportunity. They need to be thought of as medical devices, and I think that there's a role for the FDA here to prove that these things work. And when they do, they will undoubtedly provide wonderful insights to doctors and patients at the right time. And I think it's going to require huge investment. And so if you look at what Google's doing with Verily, there will be unbelievable innovation in this space with incredible upside, both on the commercial side for the manufacturers that really go the distance on it, but for healthcare in general. I think it'll be outstanding.
So we are working with teams that just establish a standard of care on this. So we use FDA devices and as well as ones that are not. But the doctors, the care team set the standard on, we're dealing with transplant patients who could have rejection issues. So we have to really kind of scrutinize that. Because Jack, as you say, the wrong device, wrong information from the wrong devices can send a patient to crises or make the doctor do the wrong diagnosis. So for our hospitals, they establish a panel of devices for that particular pathway that they want to use and just really kind of set up standardized pathways for that. That's how they're using it.
My fellow panelists all have really interesting, intriguing products, which they did an amazing job of not turning today into a pitch for, and our questioners in the audience, thank you for the same. And I don't have any product to pitch, but I did want to mention one thing that the AMA is doing that I think is really cool. It's a fun time to be involved with the AMA because it's not your father or mother's AMA, and people aren't aware of a lot of what we're doing these days beyond the usual advocacy and policy work, but we actually are investing heavily in the digital ecosystem and in trying to have physicians be more present and involved early in innovation cycles with venture capital and private equity, with entrepreneurs. So we're looking to partner with folks. We actually are deeply involved in Matter, which is an incubator in Chicago, where we have a lot of young physicians working with entrepreneurs. And we've just opened and was announced at JP Morgan last year, Health 2047, which is really a design and rapid innovation lab south of Market in San Francisco. So our goal is to give physicians back an hour a day, kind of audacious, but we want to work on products that are actually friendly to patients and physicians. We're about out of time, so I know most of our panelists are finishing at 10:30, right? Yeah, so I know the panelists might be available for a few minutes, so I'm going to ask those of you who still have questions to try and grab us in the hallway afterwards. I just want you to join me in thanking my three panelists here for a great morning. Thank all of you for coming and listening.